هنتكلم على aneurysms in general, and we will talk about aortic aneurysms especially. Can you hear me? Okay. Our subject today is aortic aneurysms. And aortic aneurysms are not very rare. You will encounter them all the way through your career as a doctor, whether in surgical outpatients or medical outpatients. So it is very important that we know something about this disease. We define aneurysms as abnormal dilatation of an artery or vein. Please notice artery or vein, not only arteries. But this definition does not apply to all aneurysms. Some of the aneurysms are not only dilatation or not pure dilatation. So if we can say it's a sac filled with blood in continuity with the interior of a blood vessel, then this will cover all types of aneurysms. Arteriomegaly is not an aneurysm by itself, but it's a diffuse dilatation and frequent elongation and tortuosity of the aortoilofemoral popliteal arteries. We classify them into type 1, 2, 3. Type 1, if it involves the abdominal aorta, the iliac and femoral vessels. Type 2, if it involves the femoral artery and popliteal arteries. And type 3, if it involves the whole thing, that means the abdominal aorta, iliac femoral arteries down to the popliteal arteries, which is more common. There is no morbidity of this disease. We can find them in some people without any problems at all. Rupture will take place only if there is superimposed aneurysmal dilatation of some parts of this ectatic vessel. When can we say there is an abdominal aortic aneurysm? If the size of the aneurysm is 4 centimeters and above. The normal aorta is between 2 and 2.5 centimeters in diameter. If it reaches 4 centimeters, we speak from an aneurysmal dilatation. But also, if the adjacent aorta is smaller than the widened aorta by 5 millimeters, then we speak about aneurysm of this dilated part. What about epidemiology? It is rare actually before the age of 55. But if it is present, then it is naturally in younger age groups with Marfan syndrome, Ehlers-Danlos syndrome, and arteria magna syndrome. We notice that with age, the rate male to female changes. So in the age 60 to 64 years, the male to female ratio is 12.6. And 70 to 74 years, the male to female ratio is 7. And down, if we get into the age of 80 and above, we found that the ratio is 4. That means with increasing age, the involvement of female will be more. It's not very rare. It's not very rare that this disease causes death. And actually, in 2.2% of all deaths in men between 70 and 74 years is caused by aneurysms. 77 are due to abdominal aortic aneurysms, and this comprises 5% of all sudden deaths. This diagram will show the death from the aortic aneurysm as a percentage of all deaths for men's age. And we notice that here between the age of 65 and well, let us say from 65 up to 75, 79, that the percentage increases. What about the prevalence? Actually, in 55 to 75 years old people, we find that aneurysms are present of all sizes in 5.5%. In aneurysms in diameter of 4 centimeters or more, we find about 2.2% of this age group. 50% higher incidence or prevalence, actually, than the general population we find in people suffering from hypertension, ischemic heart disease, peripheral vascular disease, and carotid artery disease. What about the etiology? Genetic predisposition is known. The prevalence in brothers and sons of aneurysm patients is as high as 50%. Medial disease, which is present in younger age groups, is caused by connective tissue degeneration. And this naturally we're talking about the pathological basis of aneurysms. The connective tissue degeneration based on collagenolisis, and this is caused by proteolytic activity and with presence of authentic collagenase, that this we find only in ruptured aortic aneurysms or ruptured aneurysms generally. We have always to think about the anatomy and know the build of our system. Without knowledge of anatomy, we cannot understand the disease. Remember, please, that the arterial wall or venous wall, so the wall of the arteries and veins, is composed of the following layers: intima, flat-celled endothelium, and subintima, which is a loose areolar tissue, then the media, which is a thick muscular tissue with elastic fibers, and the adventitia, which is a thick fibrous tissue, which gives the vessel its shapes, prevents it from overdistension, and gives its blood supply through the vasa vasorum. The four components of the media are smooth muscle, which provides the tone to the wall of the arteries and veins, and elastic fibers, and this determines the distensibility of the vessel. Collagen fibers give the strength to the media, and the mucopolysaccharide gives the basis or offers the basis of connective tissue. The collagen network is primarily responsible for the tensile strength of the aorta and arterial wall. Genetic factors will predispose to acquired aneurysms when there are deficiencies in the construction of collagen, which we can find in some cases or varieties of Ehlers-Danlos syndrome, or in some families with history of familial aortic aneurysms. Degeneration of the media occurs with age. This is a normal aging process. Predominantly affects the elastic fibers and smooth muscle cells. Medial cystic necrosis occurs as part of the aging process. It's just a matter of how much. The proteolysis theory of aneurysms formation tells us that there might be deficiencies of collagen and elastin in the aortic wall, and there is increased circulation levels of collagenase or elastase. There might be also decreased protease inhibitors and altered protease and antiprotease activity. Atherosclerotic disease is the most common cause of aortic stenosis, affecting mainly the abdominal aorta. And it affects predominantly people more than 60 years of age. Medial disorders, which we have been talking about, affects younger age groups. And clinically is more important. It causes early cystic medial degeneration, and this is followed later by aortoannular ectasia or acute aortic dissection. So it usually presents itself as an acute process. Male sex, advancing age, tobacco smoking, hypertension is some of the environmental influences which causes aortic disease leading to aortic aneurysms. Chronic obstructive airway disease as well, irrespective of the history of smoking. And occlusive arterial disease affecting coronary arteries, carotid, and limb arteries as well. We are not certain, actually, about the mechanisms by which environmental influences interact with the underlying genetic predisposition to produce aortic aneurysms. Most important are the three factors: sex, advanced age, and tobacco smoking. This will certainly interact with the environmental influences. What about the natural history of the disease? The diameter of the infrarenal aorta increases usually with age, more in female than in males. But there is always an increase with age in the human being. They usually begin as a local accentuation of this aging process. But once it has started, it will never stop. It will just continue and increasing in size. Local aneurysms with normal adjacent arteries we might find, but we might find generalized arterial ectasia, and we might find local dilatation within an ectatic arterial cyst. The size as a determinant of the natural history. Very small aneurysms, that means less than 4 centimeters in diameter, enlarge very slowly compared with larger ones, usually at the rate of 2 millimeters per year. Ruptures occurs only in rare cases after massive trauma to the abdomen, a blow to the abdomen or to the aneurysmal site. Small aneurysms between 4 and 5.9 centimeters in diameter, they have a rate of 6% of rupture, and if they reach 4 to 4.9 centimeters in diameter, the expansion rate is about 5 millimeters per year. The expansion rate in people with aneurysms from 5 to 5.9 diameter is 7 millimeters per year. Large aneurysms, that means larger than 6 centimeters in diameter, in these people, there is not too much chance. Without surgery, they die within 3 years because the expansion rate is higher than in the smaller aneurysms. And these people who die within 3 years, they die because of rupture of these aneurysms. We classify the aneurysms into two major groups: the congenital aneurysms and the acquired aneurysms. Congenital aneurysms, which appear in Marfan syndrome, Ehlers-Danlos syndrome, in arteria magna syndromes. We find them in radial artery aneurysm and perianeurysm in the circulus of Willis at the base of the brain. If we say congenital aneurysms, we don't mean that the aneurysm is present at birth. We mean only that there are genetic factors which lead to the formation of aneurysms later in life. Acquired aneurysms are those aneurysms which are acquired in life due to many factors. We classify them into false aneurysm and true aneurysm. And the difference is that in true aneurysms, we find in the aneurysmal sac all layers of the arterial or venous wall. So all layers of the vascular wall are present: intima, media, and adventitia. Sometimes, if we find only the adventitia, we might see it as a true as well. But false aneurysms, where the aneurysmal sac does not contain any layer or just part of the layer. According to the shape, we classify them into fusiform aneurysms, saccular aneurysms, fusiform saccular aneurysms, dissecting aneurysms, and arteriovenous fistulae. The fusiform aneurysm is called fusiform, is a symmetrical dilatation of the vascular wall. There are more seen in people with atherosclerotic disease in the abdominal aorta and mainly below the renal arteries. Because the atherosclerotic disease is a degenerative disease, there is a symmetrical dilatation of the wall. In saccular aneurysm, only eccentric dilatation, just part of the wall is dilated. And sometimes it is caused by atherosclerotic disease if there is an ulcer in the intima, which causes weakness of the media and then bulging of the artery. But usually, the saccular aneurysm appears due to other causes like trauma or infection, etc. Fusiform saccular means if we have a fusiform aneurysm and on top of that there is extra circulation of the wall. Dissecting aneurysms, these aneurysms appear because of a tear in the intima in people especially with hypertension and severe atherosclerotic disease, but people also with Marfan syndrome or Ehlers-Danlos syndrome, Ehlers-Danlos syndrome. When there is a tear in the intima, the blood will traverse the layers between the intima and media or the layers in the media itself and splits the wall into two halves. Arteriovenous fistulae can be either acquired or congenital. This is a diagram shows a fusiform aneurysm of the abdominal aorta below the renal arteries. Fusiform is symmetrical in shape, involving the whole infra-abdominal aorta, but also there is another aneurysm involving the left common iliac artery and the internal iliac artery. In this diagram, we see atherosclerotic disease of the aorta. There is not a general there is no general dilatation of the aorta, but we find a circulation. As I said, it's a circumscribed circulation at this site. Could be a weak area due to trauma or could be a weak area due to ulceration. This is what we call arteria magna syndrome or diffuse aneurysmal disease. And this is the classification which I told you about. In type 1, we found that the abdominal aorta, iliac, and femoral arteries are involved. This comprises 10.9% of cases. Type 3, 7.7%, and this is the femoral and popliteal arteries. But here, in 81.3% of the cases, we found generalized ectasia of the abdominal aorta, iliac arteries, femoral arteries, and popliteal arteries as well. This here, a drawing that shows the condition we see here on the angiogram. These are the semilunar cusps of the aortic valve. This is what we call sinus of Valsalva. There is a sinus of Valsalva dilatation, and this is an aneurysmal dilatation. And here we can see an aneurysmal dilatation of the infrarenal aorta. We can notice the tortuosity of the iliac vessels here, which indicate the presence of atherosclerotic disease as basis and cause for this aneurysm. This is chest X-ray, which shows us the dilated ascending aorta, aortic arch, descending aorta, and here is the border of the thoracic descending aorta. It's an aneurysm which we can see also on the lateral view of the chest. This is a magnetic resonance imaging of the same patient with aneurysmal dilatation extending from the end of the arch of the aorta after the subclavian artery and down, involving also the upper part of the abdominal aorta after its entrance through the aortic hiatus. A CT scan of an aneurysm of the abdominal aorta, which shows the lumen here, the wall of the aneurysm here with calcification, and here we can see a large mural thrombus. In this picture, we can see an aneurysm, but it's not atherosclerotic like this one. This here was what we call inflammatory aneurysm, seen as thickening of the wall with calcification and the lumen here in the middle. This is a diagram showing an ectatic dilatation of the whole aorta, starting from the sinus of Valsalva through the way down through until the iliac, the aorto-iliac bifurcation. And here's the arteriogram of this aneurysm. Here's an aneurysm involving only the ascending aorta and the aortic arch. And here's the angiogram showing this dilatation. Here is the aortic valve. Here is the sinus of Valsalva, corresponds to this part here. And here's the aortic arch, corresponds to this part here. This is a fusiform aneurysm of the whole abdominal aorta from the aortic hiatus down to the aorto-iliac bifurcation. This is a CT scan of a ruptured abdominal aortic aneurysm, and here a CT scan of a confined rupture. The confined rupture means the aneurysm has ruptured, but it is confined by surrounding tissue, and because the abdominal aorta lies in the retroperitoneal space. If the peritoneum is intact, they usually are confined. But usually if the peritoneum ruptures, then the aneurysm cannot be confined anymore. Another CT scan of an atherosclerotic abdominal aneurysm, inflammatory abdominal aneurysm with thickening of the wall, and here of atherosclerotic aneurysm of the abdominal aorta with free lumen and intramural thrombus. Another CT scan of a patient with an inflammatory aneurysm. Here's an arteriogram of the abdominal aorta showing irregularities of the wall. It shows aneurysmal dilatation. We know that this patient has an aneurysm, but if we do just an arteriogram of these people without other methods to assess the condition, we cannot always decide upon the size of the aneurysm, because the aneurysm might be that size, like that, but this here is only the central canal. The rest of the aneurysm will be usually filled with debris, thrombus, and other material. So the dye will run only through the central canal, which just show the irregularities. And here, the tortuosity of the common iliac vessels as a sign of diffuse atherosclerotic disease as a basis of the condition. Here's an arteriogram showing a popliteal artery aneurysm here from a saccular type, and this aneurysm was produced naturally in a patient with atherosclerotic disease. We can see here the branches of the popliteal artery. This is the posterior tibial artery, which is very narrow, and the lumen is not quite well. The anterior tibial artery with a better lumen. So the basis of this condition here is atherosclerotic disease. Here's the same patient, the MRI of this patient, which shows the dilated popliteal artery with intraluminal or mural thrombus. According to etiology, we classify them into atherosclerotic aneurysm, congenital aneurysm, traumatic, inflammatory, and infectious, which we call also mycotic. Atherosclerotic aneurysms are the most common type of the aneurysms, and as I said, involves the abdominal aorta, mainly the infrarenal part of the abdominal aorta, causing fusiform aneurysms. Congenital aneurysms are caused by medial disease, which we discussed before. Traumatic aneurysm is caused by any trauma. It can be a false aneurysm, can be dissecting aneurysm, saccular aneurysm. Any type of an aneurysm can arise from trauma. Inflammatory aneurysms, we actually talk about specific and non-specific inflammation. If we talk about specific inflammation, then we need syphilis, for example, which affects the media. We know that the syphilis causes perivasculitis. The perivasculitis will attack the vasovasorum as well. That leads to weakening of the wall. This, with deposition of gumata, will lead to the weakening of the whole wall, leading to the formation of aneurysms. These aneurysms usually appear in the thoracic aorta, in the descending thoracic aorta. Infectious has been called mycotic, and it is still called mycotic, but it does not mean it is fungus. It is bacterial infection. When it was discovered in the late 19th century, they thought it was due to fungus infection. But later on, it has been found it is due to bacterial infection. They kept the name mycotic aneurysm in use. This is an example of a mycotic aneurysm in the cubital vein in a patient who used to inject himself with drugs in the arm veins. It's a drug abuser. Here we can say a traumatic aneurysm of the subclavian artery clinically presents itself as a pulsatile mass with local symptoms and pressure against the surrounding structures of the cervical and brachial plexus. Here's the arteriogram of the same aneurysm. Here's the aortic arch, is the origin of the subclavian artery, and here is the aneurysm. This here is a mycotic aneurysm in a patient after subacute bacterial endocarditis. This patient has been treated with antibiotic, but the aneurysm remained. This is an arteriogram of a saccular aneurysm of the splenic artery found by accidental examination. How do aneurysms present clinically? Most aneurysms are small and without symptoms. But if they start to increase in size, the patients start to complain. We talk here about abdominal aortic aneurysms as the most common type. This causes chronic low backache. Any person who is a smoker or hypertensive or people with hypercholesterolemia, people with known atherosclerotic disease who complain of chronic low backache must be seen as potential candidates for abdominal aneurysms. You have to exclude abdominal aneurysms before you think of other causes like discopathies or other spinal instability. The patient might complain of a pulsating mass in the epigastrium, or they might present with gastrointestinal or urological symptoms. Thromboembolic phenomena might appear, presenting with acute low limb ischemia. Aneurysmitis might take place, causing rigors, temperatures, fatigue, generalized malaise, abdominal pain. Orthocaval fistula might appear, causing heart failure, which we call high output cardiac failure. Ureteric occlusion might appear in inflammatory aneurysms because the inflammatory process involves the retroperitoneal space. We call the retroperitoneal fibrosis. This might involve the ureters, causing hydronephrosis with all its symptoms. Duodenal obstruction might take place. Aortoduodenal fistula with bleeding into the duodenum, causing either melena or profuse bleeding leading to shock. Depends on how much blood is lost from the aorta into the duodenum. Aortic occlusion might take place, and leaking or rupture that might lead to death. People who suffer acute rupture and not operated on will die immediately or within hours. People who develop acute rupture or confined rupture or leaking, if they are operated, 60% of these people will survive. People might go into a chronic condition with chronic rupture. This will last for a few months, and people at the end will die. Investigations of aneurysms. Naturally, we have to examine the patient first. Abdominal examination in a supine position, watching the abdominal wall for abnormal pulsating movements, palpating the abdomen to find any areas of tenderness by superficial palpation, and finding the areas of pulsation. Try to assess the extent of the pulsation without applying too much pressure. We have to determine the size and extent of the aneurysm accurately. We have to know the thickness of the wall of this aneurysm. And we have to see if there is any circular dilatation. Also, to assess the importance of coexisting arterial disease. People with abdominal aortic aneurysms might have peripheral vascular disease, femoral artery disease, femoropopliteal disease, or distal arterial disease. The first line of investigation is the ultrasound examination. If it is done by an experienced person, it gives us excellent results. The advantages are it is cheap, does not cost much, freely available, accurate, reliable, and reproducible. That means we can always repeat the examination without fear. It is non-invasive and can be repeated as often as possible and as required. The disadvantages, when we say it is observer dependent, that means the examiner must be experienced to give you accurate results and finding. And also the problem with this investigation, so if the patient is obese or he has or she has a lot of abdominal gases, the picture will not be that clear as well. CT scan is an excellent tool for permanent results. We use it to discover the extent of suprarenal involvement and the thickness of the wall, and to assess the presence of intraluminal clots or calcifications of the wall. It's also used to measure the diameter of the aneurysm if the aneurysm is not tortuous. Magnetic resonance imaging and magnetic resonance angiography are very important, and they produce excellent results. They have no radiation exposure. Angiography is not always used. We use it only to assess the distal disease, if there is any femoropopliteal disease. And it also visualizes the outline of the kidneys and the relationships of the renal arteries, but it will not give us any clue about the size of the aorta, as I said, because the lumen of the aneurysm is filled with clots and debris, and cannot be seen when the dye passes through the central canal. Color Doppler is very important to detect any concomitant peripheral vascular involvement. It also gives us a clue about the distal flow. Why do we investigate the patient? We have to investigate the patient to assess the fitness of the people for major procedures, for major surgery. Cardiac function has to be assessed by taking a good cardiac history, physical examination of the chest, pulses, blood pressure monitored, ECG, chest X-ray, echocardiography. Respiratory function test must be done to assess the fitness for general anesthesia. Carotid Doppler ultrasound study to exclude carotid artery disease. And we have to do blood investigations, among which are complete blood count to exclude any inflammatory process, ESR, and the lipid profile. How do we treat aneurysms? Small aneurysms are not treated. They are just conservatively observed. Observed means we have to repeat ultrasound examination every 6 months to assess the increased size. Large aneurysms and symptomatic aneurysms are submitted to elective surgery. elective surgery. We have to admit the patient at a leisure. We prepare the patient. We do our investigations at leisure, and then we operate on these people. Leaking or ruptured aortic aneurysms need urgent surgery if the patient arrives alive in hospital. Inflammatory abdominal aneurysms, well, they cause a lot of problems because of the inflammatory process present, and operation is very difficult because during the operation we see a lot of bleeding because of the hypervascularity of the inflammatory tissue. If the patient is fit, we might operate on them, but if the patient is unfit, then we give the patient steroid therapy, symptomatic therapy, support until the patient is fit or at least kept alive for a few years. In dissecting aortic aneurysm, as I said, dissection means splitting of the arterial wall into two halves, either through the media or between the media and intima or even adventitia. If the dissection, which usually takes place in the ascending aorta, but can also take place anywhere else, but usually in the ascending aorta. If it takes place in the ascending aorta, we call it type A dissection. If it takes place in the aortic arch, we call it type C dissection. But if the dissection starts in the descending thoracic aorta, we call it type A dissection. The people present in acute dissection with severe retrosternal and back pain, sudden onset of severe pain. These people are usually hypertensive. The dissection might be antegrade or retrograde or both. Antegrade means it goes forward distally from the site of the dissection down the aorta. Retrograde means the dissection will dissect backwards also proximally to the aortic valve and heart. In type A dissection with retrograde dissection, the people might develop aortic regurgitation. If you remember the picture which I showed you of the sinus of Valsalva and aortic valve, if I were to go back to this picture, just to show you, here, if the dissection takes place here in this part here, there or there, if it goes down like that, we call it antegrade dissection. If it goes backward, we call it retrograde dissection. Retrograde dissection might damage the aortic valve, causing severe acute aortic valve regurgitation, leading to heart failure, left heart failure, and pulmonary edema. But also might rupture into the pericardium, causing pericardial tamponade with low cardiac output and later on death. But if it is antegrade, it will run downward like that. If it starts here and runs down like that, it's antegrade. So if it is an antegrade, we can operate urgently. But if it is retrograde, that means immediately, that means within hours. You have to get the patient straight away to theater. So we go back to our treatment here. So with retrograde dissection, immediate surgery. With antegrade dissection, urgent surgery. In this surgery, we have to excise the aneurysm and to replace the ascending aorta with a tube graft of material called dacron. Sometimes we have to implant the coronary arteries when we replace the ascending aorta, but sometimes we only have to replace the ascending aorta without implanting the coronary arteries, usually if the sinus of Valsalva is not involved. In type C dissection, urgent or as soon as possible. This type of dissection or type of operation on dissection of type C is difficult, and because the neck vessels arise from the aortic arch, and performing an operation in this region means we have to cut the blood supply to the brain for a while, that means the patient will die of cerebral ischemia. So in this case, we have to perform shunts so that we can operate on the aortic arch without reducing the blood supply to the brain. Type B dissection, when the dissection is in the descending aorta, or thoracic aorta, the patient is stable. We can keep the patient under close observation. We reduce his blood pressure. We treat him symptomatically until the patient is fit for surgery later on electively. Naturally, the dissection might take place in the aorta and extends down to the iliac bifurcation. In this case, the operation should be done very, very soon. Otherwise, it will lead to a renal shutdown and mesenteric ischemia. Lower limb ischemia as well with lower limb gangrene. The femoral artery, popliteal artery aneurysms, subclavian artery aneurysms, and carotid artery aneurysms, they are source of embolization. Even if they are not very big, we have to operate on them. We should not wait for the aneurysm to become big to operate, even if it is asymptomatic. Once it's found, we have to think of the potential embolization into the distal parts. If we leave a carotid artery aneurysm, it will cause CVA, embolization to the cerebral arteries. Subclavian arteries will cause embolization into the arms with gangrene of the finger and arms or hand. The popliteal artery or femoral artery will lead to lower limb ischemia. So surgery is required because of the risk of limb loss and hemiplegia, as I said. Mycotic aneurysms are treated surgically if the patient is fit with antibiotic cover. We might have to do arterial reconstruction and excision of the infected material. We might have to use open drainage with continuous irrigation and lavage with antibiotics. We might have to do some ligations, or if naturally the aneurysm is small and is in unimportant place, we might just ligate it. But if the aneurysm is in a place where we need the distal blood supply, then we have to perform bypass operations. Now we talk about vascular malformations. They are usually congenital venous disorders, venous anomalies of the lower limbs, like many minor aberrations of the lower limb veins, as a duplication of the deep veins, or different levels of short saphenous veins termination. That means short saphenous vein usually opens into the popliteal vein, but some people it might just open distal to the original place or site. We might have an unusually large interconnecting branches between the short and long saphenous veins. The persistence of a lateral vein in the lateral aspect of the lower limb. This lateral vein extends along the lateral side of the leg and can cause also problems. The reason I'll tell you later. Here, the persistent lateral vein of the leg and thigh. Why does it cause problems? Because it forms a massive valveless channel. Valveless channel means the venous return to the heart is not effective through this artery, according to the physiological data, because the muscle pump doesn't work. As you know, the muscle pump means muscle contractility of the calf muscles and integrity of the venous valves to direct the blood upwards, and the integrity of the deep fascia. So if we have a valveless vein, that means the muscle pump is not effective. So the venous return to the heart is not effective. And that naturally will lead to problems. This lateral vein of the thigh and leg runs superficially up the outer side of the right leg and thigh, terminates by opening into the profunda femoris or the internal iliac vein. Cavernous hemangiomas are mostly localized. They cause discomfort, and the angiogram will show caverns, venous caverns, and enlargement of local veins, so local enlargement of the veins. Extensive venous angiomatosis we call also phleboangiomatosis or phlebectasia. There might be abnormal development of the capillaries and veins as a localized malformation, capillary angiomas. Looks like strawberry nevus. This is what we call strawberry nevus. They are dark, red in color, and present at birth, but might disappear with age. Cavernous hemangiomas, however, remain. They are swelling, large blood-filled spaces, and persistent, becomes larger with age, and affect the skin and subcutaneous tissue, and may extend deeply into deeper tissues and even the bones. Extensive venous angiomatosis affects large areas, and when the skin is involved, it looks dark purple, irregular, with compressible swellings because they are cavernous, and can extend to muscle bones as well. The lateral vein can be present in these people, and as I said, the venous return in the lower leg is reduced and leads to the formation of varicose veins and venous ulcers. Klippel-Trenaunay syndrome is an extensive venous abnormality often present, and overgrowth of the bones is observed. Treatment of these conditions is naturally dependent on the clinical symptoms. They are sometimes cosmetically, and if the cavernous angiomas involve deep structures and bones, it will be sometimes very difficult. And thank you very much.